So we'll move on to a new topic today. We'll look at soft tissue and bone injuries. So far we've looked at all these kind of things, and now we're down here through ligaments and looking at the bones. So let's look a little bit, start with nerve entrapments. So you can have acute trauma that can either stretch a nerve or compress a nerve or tear it. Repetitive microtrauma, which is common in sports type injuries. You can also get nerve entrapment from inappropriate footwear, such as high heels. From internal derangement, both congenital and acquired lesions can impact the nerves. Masses, internal and external. Hypertrophic muscles, inflammatory changes, and then plantar fascial tears can also, all of these can be involved with neuropathies. So one of the most common, probably the most common in this area is the peroneal nerve. It's the most common lower extremity neuropathy, and it generally presents with foot drop. The deep peroneal nerve leads to the anterior tarsal tunnel syndrome. Superficial peroneal nerve can also have symptoms, and then you have the sural nerve where you can get typically this is more involved with systemic neuropathies, which is whereas the peroneal nerve is a little bit more commonly associated with trauma and surgery. And then there's the saphenous nerve, which can be affected with knee surgery. Okay, so let's talk a little bit about foot drop, since that's a fairly common clinical presentation. So we can see the nerves come down from the lumbar area, primarily the L5 level, comes through the sciatic nerve down into the down to the or up here. We have the sciatic nerve coming down here. Then you have the tibial nerve, and the common peroneal nerve comes off here laterally. As you know, the common peroneal nerve comes over here, comes around the fibular head, and this is a common location of injury. It gives off the recurrent articular nerve back into the proximal tibiofibular joint, and then it goes distally and starts bifurcating into the deep and superficial peroneal nerves. So here's kind of foot drop, and the things you think about, you need to think about where starting from where the nerves come out, which would be the lumbar spine, can actually cause foot drops. If you see palpable masses, then you need to look into the area of the palpable mass. And then you basically turn on clinical evidence as to where you think the most likelihood of the nerve involvement might be, and then we typically do MRI imaging in the area where we're most concerned. And often for us, the most concerned area is going to be around the fibular head. So if we look at the different muscles that are innervated by these nerves, the tibial nerve innervates the more posterior muscles back here. The deep peroneal nerve and the superficial peroneal nerves innervate the extensor complex here, and that's when you get foot drop, is because you lose the function of the extensor muscles and the anterior compartment of the leg in this area. So most common, I've seen mostly the deep peroneal nerve with the tibialis anterior and the extensor digitorum longus muscles are involved. The superficial peroneal nerve, you get the
peroneus longus.
Thank you. Peroneus longus and brevis muscles. Thank you. I'm just blocking there, John. Thank you for the help. So common peroneal neuropathy, you can either commonly involved with compression or stretch injury. As we kind of said before, sports, motor vehicle accident, fractures, post-surgery, and the symptoms of foot drop.
So, one other one, crossing legs.
Oh, okay. Crossing legs. That's right.
That's not seen very often in females, but it is seen in males.
Okay.
I saw two cases, one bilateral was an attorney, and one unilateral was my accountant. Both kind of skinny, and they cross their legs like girls do. Right next,
Okay.
it's the peroneal nerve was right on top of the knee, the other knee.
Then they had a compression of it.
And then got compression and got a foot drop. One needed decompression, the other one did not. Most of them will recover without any treatment other than stop doing what you're doing.
Thanks.
But you really get quite a foot drop. Usually you get L4-5 injuries, the disc, which catches the fifth lumbar nerve, but this common peroneal nerve is not uncommon. Like we used to say in doing surgery around the knee, you look at that. If you ever see the nerve, you're already too late.
All right. So we have a 27-year-old male with knee pain after a motor vehicle accident and new foot drop.
So we're up in the thigh. This is one cut. This is the next cut.
Okay. I can't tell if that's that common peroneal nerve and it disappears.
Okay, there's the common peroneal nerve, and then there you can see it's very swollen and cystic.
Okay.
And then more peripherally, you can see it's also abnormal signal, abnormal configuration, enlarged. We go farther down, we're here.
Okay. I think I see it there. It does look a little bit thickened and increased in signal. Here it's thickened and increased in signal. Gosh, it's hard to see here. Okay, so there it is. Thickened and increased signal, and I don't see it very well distally here.
Here's the sagittal images.
Okay. There we can see it again. Again, I don't see it distally, but it's thickened and increased in signal. So I think if he had an injury to the posterior knee, it was transected or stretched.
This was a stretch injury, whereas I think some of the fibers were completely disrupted there, where you saw that cystic change, but the epineurium was still intact in that area. We'll talk about treatment a little bit later, but this is a situation where you'd certainly want to get neurosurgical consult, and they might want to operate on this and reanastomosis the nerve. But we'll talk about treatment options later.
Okay, 18-year-old male with dorsiflexion weakness after severe inversion injury in playing rugby. So we see a lot of signal within the peroneal, it's probably the peroneal longus muscle, both peroneal muscles. And it's kind of diffuse, diffuse edema. And now that you also see that there's edema in the other extensors, the anterior tibialis and the extensor. So there's got to be a nerve injury and you're getting early denervation.
This is a common peroneal injury. Here it looks like it'd just be the superficial peroneal, but then when you go more distally, you see the other tendons are involved, so it's a common peroneal lesion. Okay, Ashu, what do you think about this case?
So it's a 40-year-old male with puncture wound on the anterior calf, pain unable to dorsiflex, rule out infection. Looking at this, you can see looks like a well-corticated fragment at the arrow. And let's see here. Oh, okay, so there's a lot of soft, I guess that intramuscular edema actually that's involving the gastrocnemius and the soleus. And I don't know if that's the nerve right there. It looks very thick.
That was more than a nerve.
Okay. Let me just let me go back here. Let's go back to me. Okay. So puncture wound on the anterior calf, pain unable to dorsiflex, rule out infection. So this is actually the area of the puncture wound. Maybe some soft tissue swelling here. Here's the MR examination, and so what we see is and here if we come back here, you can see kind of the level that we're at. You can see all this kind of fluid collection in through here, and then this obviously is the tibia, presumably the fibula back here, but I'm not so sure. One thing that you need to look at when you see these kind of complex cases is you also have to look at the flow effects here. And if this case, you can see that there's prominent flow effects going right through this area, anterior, posterior, in the phase-encoded direction.
There's some pulsation artifact.
There's actually the fibula over here. Okay.
Right. Is this a clot here or an AV fistula?
Okay, and then we see this. Okay, and here's another view of this. Again, here you can see the flow artifacts going back and forth. Okay, this was a tibial artery pseudoaneurysm with a lot of hematoma surrounding it. So I guess it's in the area of nerves, but I didn't know where else to put this case. The patient actually presented with neurologic findings, but it's all from a big pseudoaneurysm. Now, if we go to the dorsal side, we have the deep peroneal nerve and the superficial peroneal nerves. The deep ones go deep to the extensor retinaculum. The superficial ones go superficial to that. And I really haven't really found a lot of abnormalities in this distribution in clinical practice. So if we look at the nerve and entrapment syndromes, again, the tibial nerve tends to get the flexors, so you have problems in plantar flexion. The posterior tibial nerve, the syndromes associated with this are called tarsal tunnel syndrome. Medial plantar nerve, it's Jogger's foot. The digital nerves distally are Morton's neuromas, and the lateral plantar nerve is Baxter's neuropathy. So let's go through some of these now, looking at the tibial nerve distribution. So here's a 27-year-old female.
So she had an injection with Phenergan 4 months ago and intense initial pain. Now less pain and increasing calf mass. So we have STIR and T1 post-contrast images. It looks like there's asymmetric edema in that right posterior compartment musculature. I'm not sure if he could have damaged the sciatic nerve with the injection.
I mean, the posterior tibial.
Posterior tibial. Oh, distal. Okay. And then pre and post contrast.
The injection was up in the buttock, so the injection would have affected the sciatic nerve. You're completely right. But if you look distally, the only component of that we see abnormal is really the tibial nerve.
Tibial nerve, I see. Okay. Yeah, and
we see a little bit of
increased enhancement.
One thing to tell you is that different anatomy books have a different name for some of these nerves. So Cunningham's versus Gray's Anatomy, etc.
Okay.
So don't get confused with that, because it's it depends on what school you went to. You get a different nerve in this area.
Yeah.
I looked that up several years ago, and I found quite a lot of differences in different Grand Atlas versus Netters and so on.
Yeah. So going distally with the tibial nerve, it divides here, and then you've got the medial plantar nerve innervation area, the lateral plantar nerve, all through here, and then this recurrent nerve here that you're all aware of is Baxter's nerve. It goes superior to the origin of the plantar fascia underneath the calcaneus, and can be injured here when people have injuries to the origin of the fascia, and it innervates the adductor digiti minimi muscle out here. So for a long time, when we saw atrophy of the adductor digiti minimi, we would call Baxter's neuropathy, and that may be the case. It turns out, however, that most people who have just atrophy of the adductor digiti minimi do not really have any significant pathology at the origin of the plantar fascia. It still may be that you get trauma to the nerve going through here, but the atrophy of the adductor digiti minimi does not seem to really correlate very well with what we used to call, quote, plantar fasciitis, which we now know are tears of the origin of the plantar fascia. So let's.
That treatment can cause problem.
Yeah, the treatment can if you inject a lot of stuff in there, right? And then the tarsal tunnel syndrome. So this is the entrapment of the posterior tibial nerve or its branches in the region of the tarsal tunnel. If it's proximal, it's a tibio-talar tunnel involvement. Distally, it's a talocalcaneal tunnel involvement. And the symptoms are burning, pain on the medial plantar aspect of the foot with paresthesia, tenderness, and a percussion sign. So if we look at these nerves in the upper area, in the tibio-talar area, we're up here right about at the level of the mortise joint. And here we have the flexor hallucis longus, the posterior tibialis, and the flexor digitorum tendons. And between these groups are the branches of the tibial nerve coming down through here. This is where it breaks up into the different components. If we go lower, we get down into the lower area down here where you've got separation between those that are going to the medial and those that are going lateral. But you can also get nerve involvement down here in the lower talocalcaneal region. Yeah, there are vessels in there as well. Yeah, this is actually the artery, these are the veins, and these are the nerves.
There was a time
Over here.
before MRI and maybe CT where tarsal tunnel was believed not to exist, and it was a psychological problem. But that was changed once we got the MRI going.
Oh, interesting.
Because in my training, I remember we didn't cut to try to find a nerve and release it because we didn't feel that there was enough evidence to diagnose it and release the scar tissue, which frequently is the cause of the problem.
Thanks, John. Great. Okay, so let me go through the anatomy here then, since it was right. This is the flexor hallucis longus, flexor digitorum, posterior tibialis. These are the nerves, the medial and lateral. That's the artery, and these are the veins on either side, and this is the retinaculum coming out through here. And here you can see the retinaculum, higher up the retinaculum there, artery, veins, the two nerves, medial and lateral, and there's the flexor hallucis longus. Okay. So what do you think of this one, Michael?
All right, symptoms of tarsal tunnel. Okay, so there's a large cystic structure right there adjacent to the medial calcaneus, kind of impinging on, you know, the adjacent structures, that tendon, and I assume it's impinging on the neurovascular bundle as it passes through. So this is good, yeah. So this can be causing mass effect and entrapment of that nerve.
This is a patient who had symptoms of tarsal tunnel, so that's one cause. Ashley, what do you think of this case? Patient had tarsal tunnel syndrome.
Here we can see bright T2 signal in the kind of macrolobulated along the tarsal tunnel. You can see there's definitely going to be compression of the tibial nerve and the medial plantar and lateral plantar nerves here. It doesn't look like a typical ganglion cyst to me. I mean, it could be a macrolobulated ganglion cyst, but it doesn't look like that. And then, is that the GRE or?
Okay. So here's the flexor digitorum, there's the flexor hallucis. The nerves are go right in here, right?
Right, yeah, there's compression of the nerves there.
Ganglion cysts lobulate. I don't.
Yeah, I mean, I don't. It kind of follows actually. I've seen a case like this. It was a Varix.
Well, ganglion cysts can occur any place.
Yeah, I mean, it could be cysts as well, but it's kind of following along the plantar surface there. And I think there's actually flow signal. Yeah, that I've seen a case like this. It's Venous Varix.
Yeah. Well, you're right. That's for sure. But it can occur in that region.
Yeah.
I guess you can also think about schwannomas, right? Or nerve sheath tumors.
Yeah, you
can look different.
Yeah, they look different than that. We should see some schwannomas later.
Okay, so like atypical tarsal tunnel syndrome.
And I don't know what they meant by atypical. That's in history.
I do see effacement of fat within the sinus tarsi and edema on the stir images. This could be sinus tarsi syndrome. Here we can see again effacement of fat in the sinus tarsi and edema. I don't see any fluid collections in the region of the tibial nerve. Yeah, I would think this would be a sinus tarsi syndrome. Tarsal tunnel syndrome.
This was a patient who had rheumatoid arthritis, and this is all inflammatory disease, and it was affecting the nerve, giving them symptoms of tarsal tunnel.
And that's where podiatrists and some orthopedic surgeons used to inject cortisone into to heal tarsal tunnel syndrome, and they were treating the wrong condition. They were treating instability, so it's kind of interesting how history develops things.
Okay, Michael.
So it looks like there may be degenerative changes in the subtalar joint, and then there's soft tissue infiltration in the region, where it's circled in the tarsal tunnel. And it also looks like there's effacement of the fat in the sinus tarsi. So there's like sinus tarsi syndrome and maybe like scarring within the tarsal tunnel, kind of similar to the other one. What's causing? I don't really see the ligaments within the sinus tarsi, so I was assuming it's sinus tarsi syndrome potentially, and those erosions maybe.
Subtalar instability.
Yeah. Yeah.
This was rheumatoid arthritis. Okay. Inflammatory pannus tissue, in this case affecting the nerves and also getting erosions in the sinus tarsi, right? But I think it could also be with chronic degenerative disease and instability. This could all be scar tissue and not inflammatory pannus. But this was rheumatoid arthritis. Ashley, this is another patient who came in with tarsal tunnel syndrome.
Looking at the tarsal tunnel here, I do see some ill-defined soft tissue in the region of the tarsal tunnel, pretty heterogeneous. Could be another inflammatory arthropathy, but
Okay. This patient did not have inflammatory arthropathy, but that's a good thought. I think certainly would look into that. And then you'd need to look at the sinus tarsi, because typically if it is rheumatoid arthritis or psoriatic arthritis, you should have disease in the sinus tarsi. But this was an old shotgun injury, and it's scarring from a gunshot wound.
let's see.
I didn't get the details of how he got shot.
Okay, so here we can see marked effacement of the fat with fluid signal intensity along the tarsal tunnel. I guess this could be inflammatory arthropathy, or it could be gout. Here again we can see effacement of the fat along the tarsal tunnel. Else. Infection. Okay, so then it's less likely to be inflammatory. I
That's possible. Gout's usually at indices. I haven't really seen gout kind of in the soft tissues like this, but I guess that's possible.
Okay.
What else could you think of?
Some kind of infection if they're diabetic or they have any symptoms of infection.
It's sharply duplicated. It's mostly dark in all sequences.
Okay.
I guess it could be some sort of chronic infection. Actinomycosis. I've seen this with actinomycosis.
Get closer to the mic, John.
Oh, sorry. Yeah, it could be some sort of chronic infection, but those are unlikely. I have seen a case of actinomycosis look a little bit like this, chronic recurring, and it had been draining with sulfur granules for a number of years. But most infections, certainly most infections you'd get with diabetes, would have a lot more, the margins wouldn't be so sharp, and you'd have a lot more kind of acute edema. This really looks like much more like a mass.
I mean, I guess there's always a rare synovial sarcoma.
Okay, this was a sarcoma. We have to remember that those things still occur. I don't remember whether this was a synovial sarcoma or I forgot the actual tissue type of this. So then there's Jogger's foot. It's compression of the medial plantar nerve between the navicular tuberosity and the abductor hallucis muscle. And with that, you get heel and arch pain, tenderness, and numbness from jogging. And the pathology is here around the knot of Henry, where the flexor hallucis longus and flexor digitorum cross on the way out to the toes. And this is the medial plantar nerve branches right in this area. I don't have any good examples of this. I think I will show some knot of Henry problems later, where you get a lot of fluid within the tendon sheaths here, and that can compress the nerves here and produce that. But I haven't actually seen a documented case of Jogger's foot.
Okay. So we have increased or hyperintense stir signal in between the third and fourth metatarsal heads. It may be kind of discrete. I mean, one thing you think of in this area is like a Morton's neuroma, which is, just kind of fibrous type scar tissue.
This is one side. This is the patient's opposite side.
Okay, so they have a similar finding in between the first, second, and the third and the fourth.
So this patient had bilateral
Morton's
neuromas. So tell me a little bit about the patient.
Bilateral Morton's neuromas.
What's the sex of the patient?
I don't actually know the. I'm gonna guess female.
It's probably female.
Nah.
Most common is between first and second,
Mm-hmm.
than any of the others.
But if Morton's neuromas are associated with some
Yes,
are finding, I assume they're associated with, footwear, correct? Was the one connected from increased pressure.
basically tight shoes and activity with scar tissue, and the nerve is squeezed into small objects rather than a normal nerve tissue. One of the things about Morton's neuroma, usually you can treat it conservatively and do okay on a cortisone shot or wider footwear, which the women don't like to cooperate with. So they wind up with surgery. One of the problems is you get a neuroma that's really difficult to treat. Then you have to go deeper into the foot. So the idea is to cut the proximal portion of the nerve when you dissect the area a little further backward rather than close to the joint. And then you avoid the neuroma pinching between the two bones.
Yeah, this is actually fairly common in high-level athletes because these are repetitive trauma to the interdigital nerve, which is a distal end of the plantar nerve in this location. These really are post-traumatic. It's almost like when you transect a nerve and it retracts, one end gets bulbous and big. That's kind of what's happening here, except the nerve may not be completely transected. You've just beaten the hell out of it.
It's got pinches.
Yeah, pinches it. And these are common in high heels. And if you come from Texas, they're also common in cowboy boots. So if those of you have worn cowboy boots, you know that the way they're set is your foot tends to slide toward the toes, and you get compression of the metatarsophalangeal joints a lot with cowboy boots, and they're associated with Morton's neuromas.
Cowboys are not supposed to walk, John.
Yeah, that's right. So as long as they stay in the saddle, that they get other problems like saddle sores, but they don't get the Morton's neuromas. It's when they get up and start dancing in their cowboy boots that they get the Morton's.
Well, I've taken out enough of these to last me a lifetime.
Okay.
People just don't cooperate with your suggestion of treatment.
Yeah. And then there's the inferior calcaneal nerve, or Baxter's nerve, which we talked about earlier, comes just in front of the posterior aspect of the calcaneus, above the plantar fascia attachment there, and it comes over and innervates the adductor digiti minimi muscle. And these tend to occur in runners and toe athletes, where you get a lot of trauma in this area. It's associated with heel spurs and plantar fasciitis clinically. Again, as we talked about before, a heel spur is really the body's attempt to try to heal partial avulsion tears of the origin of the plantar fascia from the calcaneus. So these indicate that you've got trauma in the area of Baxter's nerve, and expect it to be associated with neuropathy. John?
Heel spurs actually do not cause it. 50% plus of individuals have heel spurs after the age of 30, and they don't have Baxter's neuromas.
Right.
Most of these are caused by individuals operating on plantar fascia too close to the bone.
I can believe that too. And then and they tend to present with medial heel pain late in the day after walking on it all day long, and denervation of the adductor digiti minimi. But as I said before, most patients who have focal atrophy of the adductor digiti minimi do not have the other symptoms of Baxter's neuropathy. And this brings us to a pretty common clinical problem, which is heel pain syndrome, which typically is due to calcaneal stress fractures. Well, or calcaneal fractures, trabecular fractures, plantar fascial injuries, fat pad injuries, and Baxter's neuropathy. So this was a study done at Harvard a number of years ago, but I'm sure there are others like it, looking at running between people who run barefoot versus people who run with shoes. That is specifically shoes with a lot of heel padding, like you're seeing right here. And the concept behind this is that the heel pain syndrome is very common in runners. So what it is about runners that may produce it? And obviously, initially you'll think, well, it's the impaction of the calcaneus during the running process, which makes sense. The interesting thing is, so what they hypothesized that the mechanics of running are different between people who are wearing shoes and people who are not wearing shoes. And the human body actually developed through the last couple 100,000 years primarily by humans that were not wearing shoes. So they looked at how the bones, muscle, tendons, and joints absorb stress as they run. And if you have shoes, that's what they did is they have people run on a force plate here, so they could measure the amount of force that the feet were putting down on the ground below them as they ran. And what you can see here, you get a big impaction here, a lot of force down, and then you lift your foot up, and then the other foot comes down. So here we can see the forces on the 2 feet as you're running. Obviously, when both feet are off the ground, there's no force, and then you get this typical force pattern as they're running. So this is what the pattern looks like when you have shoes on. And what you get here is a big heel strike right when the foot initially strikes the ground. Now here's someone who's running without shoes, and then here we can see what the pattern looks like. And I want to go back to look at the other one in a minute. And you can see that there's some subtle differences in the force that's placed up on the ground as they're running. And if we go back, what I'd like you to do, look, let's go. If you look at the heel strike, that's the key difference between here. And if you notice when you're running with shoes on, you'll get a very forceful heel strike, so a lot of pressure will be placed on the heel. Whereas if you run barefoot, you'll find that the initial strike is not on the heel, and therefore you don't get that big impaction on the heel. So look, see the heel right there. There you get this big strike on the heel. And watch the heel come down again. Bang, right there. It's primarily the initial contact is on the heel. Now look what happens when people people are running without shoes. Now the impact there is primarily on the foot. You don't get that big initial heel impaction. You come down primarily on the mid and distal foot, and so you don't get that big impact of trauma on the heel when you run without shoes. Now,
and the shoe probably has an orthosis in it.
It could. It could.
For higher arch, which is also a boo-boo.
Yeah. We're going to talk about that either later.
I know, and I just mentioned it.
Yeah, exactly, because we're going to talk a lot about that also. Now, so what's happening? So actually, well, we can talk about shoes. So there was after the study came out, there was a lot of pressure for kind of minimalists using shoes with less padding, and there are some other issues that could occur with that. But now, if you look, most sprinters when they run, they have very thin heels, one to make them lighter, but also when you sprint, even with shoes on, you don't get the heel strike because all of the you're trying to run as fast as you can. In order to do that, you strike primarily with the forefoot and then push off with the toes. And that allows you to get much more speed when you're running. Whereas when you jog, and it's the reason why John is not a big fan of jogging as a source of exercise, you get primarily a big heel strike, which can lead to the problems we're talking about right now. Okay, so
I recommend walking. Yeah. If you're running, run away from somebody.
Especially during COVID.
Yeah, you're right.
Okay, so who's next?
Somebody with a knife or a gun.
Right. Who is last? Anybody know?
Okay. I think I'm next.
Okay, go ahead, Ashu. So there's someone with heel pain, and this is a lateral X-ray.
Looking at that heel, right where you'd normally see a plantar spur, I think there's some fraying of the inferior calcaneus there.
I think that may be a little bit of artifact that this was a photograph of an X-ray, and we can see some X-ray stuff there. But that's a good thought.
I don't think that there's any abnormality here.
Yeah.
Remember, this is also magnified.
Yeah. So,
yeah.
But that's a good thought, Ashu. But I'm basically pointing this out as really probably being normal. And then we did MR scans of both heels. The asymptomatic one is on the left. The symptomatic one is on the right. So what do you see here?
Well, there's a plantar spur on both heels, but the symptomatic side it's bigger, and there's a lot less fat between the calcaneus and that plantar spur. I think it's almost effaced there.
You mean down?
Superior to that, and there's also thickening of the plantar. Is there some thickening of the plantar fascia there?
There.
Yeah.
That looks pretty thin over there. Maybe a little bit, but not a lot. I don't see much with the bone here. These little plantar spurs, like John was saying. I think the one thing, if you don't think anything else out of this lecture, is that the plantar spurs are not a cause of pathology. They're the body's attempt to heal the pathology that's occurring. Plantar fascias are not a cause of symptoms. And where a lot of people in the past have gotten into trouble, and still a lot of people now who see podiatrists get into trouble, is when you resect the plantar fascia, thinking that's the cause of the symptoms, those patients tend not to do very well. But we'll come back to that and talk about it.
Awful. Operating on heel spurs is a disaster for most cases.
Yeah, but it used to be a very common surgery.
Oh, I know. I was involved in the podiatry stuff.
Yeah.
I don't want to go into politics of it.
Yeah, but even when it's edematous secondary to the other pathologies that are actually the root cause of the problem that we'll be talking about in other lectures. If you notice here, we can see that there is, on this T1 weighted images, signal loss within the fat out down here near the attachment of the Achilles. And I have this to kind of point out that when you're talking about heel pain syndrome, you have to include Achilles pathology. And actually, often there is mechanical, there actually is soft tissue connection between the attachment of the Achilles tendon and actually the plantar fascia here. So this whole area can be involved in the pathology. So you have to be sure and look at the Achilles tendon insertion. And this is calcaneal stress fracture, or what I usually call these now are trabecular bone injuries. Okay. Another patient who came in with similar symptoms. Jennifer, what do you think of this case?
So there's marrow edema within the kind of inferior posterior aspect of the calcaneus near the attachment of the plantar fascia, and then also extending upward. So I guess if we were considering that soft tissue goes all the way across, that could be injury of the plantar fascia and as well as the adjacent soft tissue. Yeah.
The primary problem here is the bone.
Right.
Everything is involved here.
Sure.
Yeah, so this is a calcaneal.
Everything is inflamed, not just the plantar fascia, but you're going on to fracture of the calcaneus.
So this needs to be treated as a calcaneal fracture. And fortunately, the cortex is still intact, so this will heal very nicely.
Non-weight bearing might last for a while.
And the important thing here is to call it what it is, which is a trabecular fracture, not fasciitis or plantar fasciitis or something like that, because the proper treatment for this is not to inject it with steroids. Okay. Another patient with acute onset heel pain.
Okay, so this first thing I noticed on the stir image is they have quite a bit of edema in that kind of posterior superior calcaneus. Radiograph, you can really see that they have a very large posterior calcaneal Achilles enthesophyte. The Achilles tendon distally, I think, looks like it's grossly intact. So I don't know if these, I don't know if, I wonder if it's just really bad traction changes or if there's like a trabecular bone injury as well.
Yeah, so this is a trabecular calcaneus. So you can get heel pain with bone injuries anywhere back here in the dorsal part of the calcaneus. Okay.
This is a jogger, right, John?
Yes, an older jogger. Ashu, what do you think? This is a mid-age jogger.
So we can see a fracture plane extending through the posterior calcaneus. We see a lot of bone marrow edema. I think, there's no displacement here, but this looks like a stress fracture.
Okay.
I don't know if it goes all the way through the cortex.
Yeah, so it's an incomplete overuse fracture, and again, basically the treatment is rest, allow it to heal.
It goes swimming.
So this is another patient with kind of severe. This patient actually had bilateral heel pain.
Okay, so here we can see a comminuted fracture of the calcaneus. It looks like there's both longitudinal and transverse components, and there is some cortical breakthrough, and there is some displacement, some of the distal fracture fragments purely.
What would you recommend for this patient diagnostically besides what you're looking at?
CT.
Besides that?
Plain films.
No, well, that's from the get-go.
Right.
I'm thinking of lumbar spine.
Lumbar spine. Oh.
People get fractures falling off heights, and the lumbar spine is frequently fractured and missed. So you routinely in the emergency room x-ray the lumbar spine to look for compression fractures, because these are so painful that people do not feel the back.
Excellent, John. Thank you.
That's very important. Very important.
So this patient fell from a height onto the calcanea bilaterally, and I don't remember whether this patient had a fracture of the lumbar spine or not, but John's correct. That's whenever you see this, you have to be concerned about the lumbar spine. Very good. Okay, so let's go on and talk a little bit about the plantar fascia. So the plantar fascia originates on the plantar aspect of the calcaneus and then extends along the plantar aspect of the foot. And as you can see here, then inserts distally into the distal metatarsal bones with some little connections between the two. The most common location for an injury is at the bony origin here at the calcaneus, though occasionally you could get midsubstance tears as well. So the normal plantar fascia should be nice and thin, nice and black, all the way up to the bone, no edema within the bone adjacent to it, and the soft tissue planes are fine. Now here, this patient was actually an athlete and has some a loss of the fat on the plantar aspect of the foot which is just due to chronic use and pounding, but the plantar fascia is normal. Patient also has a little bit of peritendinitis up here, also due to overuse. But here, this is a nice normal plantar fascia. And Baxter's nerve would sit right in this area, right in through here, coming across. Okay. Sorry, who was the last one? I think it's Mike. That's right. Yeah.
Okay. So we see there's pretty significant thickening of the proximal plantar fascia with increased signal, but it appears grossly intact. So this being like a tendinosis and partial tear of the plantar fascia, which may be called fasciitis.
Okay, so this is not the most common type. This is a little bit more distal. Most commonly, it's right here at the bone interface. Most people call this plantar fasciitis. As you guys know here, I'm really opposed to that term. A lot of people will treat these with steroid injections, which helps with symptoms, but it slows down the healing process since this is a tear and can convert an acute lesions into more of a chronic lesion. If they're small, then that's probably not a big issue, but there is growing evidence that steroid injections may be a significant problem causing chronic symptoms in these patients. And one of the problems is this is an area that's not well vascularized, and it typically takes, if you have a significant injury, it takes 6 to 9 months for these to heal. But that can be prolonged with multiple steroid injections, even though it makes the patient feel better acutely. Okay. Ashley, what do you think of this case?
At the plantar fascial origin on the calcaneus, you can see signal and maybe some discontinuity. This is definitely, I think this is a plantar fascial tear, plantar inflammation at the origin with thickening.
Yeah. Okay, so this is the old term plantar fasciitis at the origin here. Again, I never use the term plantar fasciitis in reports anymore. I call all these plantar fascial tears. Okay.
Okay, so here we can see some irregularity of the plantar fascia just distal to the calcaneal attachment, and there's some surrounding soft tissue edema. So this looks like a partial tear of the plantar fascia. Then we can see some adjacent muscle edema.
So this is a diffuse tear. You also have a grade 1 strain of the muscle as well. Immediately there.
Okay, so we see thickening and abnormal increased signal right at the central kind of plantar aponeurosis at the calcaneal attachment. There's a little bit of edema in the adjacent calcaneus as well as parafascial edema. So I mean, it's just going to be, partial tear and chronic traction fasciitis.
There are various devices that you can put on the heel or on the foot, orthoses and so on, that may be helpful to treat these. I have injected a good number of people, including my father-in-law's heel area. You don't inject into the fascia, you inject around it, and with an anesthetic. And then they have a considerable relief just from that injection. And you teach them not to walk for a while and take it easy, and the symptoms subside. So I wouldn't say that you do not inject the heel for this problem. Campbell still uses the word fasciitis, but they don't talk about doing surgery or anything like that. But I had to inject my father-in-law more than once, 30 years apart. and I was still married, the same girl.
All right. Okay.
And then we misdiagnosed my father-in-law the last time, but that's when we had MRI
Oh.
because we didn't take X-rays. We can get to that when you show it, John. I don't know whether you're going to show it or not.
I don't remember that, John. What was it?
Well, one of our fellows was practicing in the Temecula area.
Right.
I can't remember his name anymore. And we had my father-in-law get an MRI there, and everything looked good. And then I said, why don't you get an X-ray just to see if there's any calcium there?
Oh, right.
Because I had injected that area many years ago.
I will show that. I remember that now.
And sure enough, there was a whole bunch of calcium.
Do that later.
Okay, 55-year-old male felt pop 24 hours earlier playing tennis. So it looks like there's complete disruption of the plantar fascia with a significant amount of surrounding edema. The muscle soft tissue, so this is going to be compatible with like an acute fascial tear. And it looks like it's full thickness in the midsubstance.
Okay. So the symptoms you can get with this, in this area, there are a number of conditions that can present fairly similarly. Plantar fascial tears, Jogger's foot, Baxter's neuropathy, fat pad contusion, and muscle tears in this area can all present similarly. So MR can be helpful in differentiating which of these is the case. And I don't think I've shown an acute fat pad contusion yet, but we should later. That's basically where everything else is normal, but you have a focal area of edema within the subcutaneous fat just underlying the calcaneus. And then most of these that we see are more in the chronic phase, where you get thickening and increased signal intensity at the origin of the plantar fascia, usually the metal band here. Occasionally you get a little bit of edema in the bone due to traction injury in this location as well. As John was saying, if you have more chronic disease, like we've seen elsewhere in many places, you can get healing with bone formation within the tendon or ligament, however you want to call it here. I guess technically this would be a ligament, the plantar fascial ligament here. And that's also
my father-in-law had a bone type of calcification above the fascia in the midfoot area, all along the.
right. I think I'm going to show that in a little bit, John.
Okay, John.
I believe I am. And here's another chronic case where we have a tear or just fat interposed and where there's the plantar fascial tear. And this is another chronic case. Okay. All right. And then let's see, Ashu, what do you think of this case?
You can see a significant edema at the calcaneus and throughout the muscles here. I think this is the abductor. We have the flexor digitorum brevis, and a lot of fluid. It looks like there's focal fat posteriorly, but it's probably just a complete detachment from the calcaneal insertion. I'd like to see it on a sagittal, see if this is a full thickness tear.
Let's see. There's the sagittal.
Okay. That looks like a complete tear, mid-substance.
There's a sagittal. And then Dr. Yurgudis, I think this is the case you're talking about, John, wanted x-rays, and here's what the x-rays showed.
Oh, okay.
That's my father-in-law right there.
Yeah.
Mm-hmm.
So in terms
of
of
heterotopic ossification.
These areas of fat were all ossicles.
Yep.
including this one right here. So those are all ossical. So John's right. Sometimes X-rays are actually helpful. Not often, but occasionally.
It's not 20 years, actually, it was 30. But I cured him twice with injection of cortisone.
Yep. Okay, well, why don't we stop here? And we will not have lecture tomorrow. I have meetings all afternoon tomorrow. But we can